Hello friends. So today I'll be talking on this topic hyperglycemia in ICU. So this talk I gave in Raipur Critical Care Conference on 4th September 2022. So the topics that I would cover in this, it's a very important and pertinent topic for all intensive care practitioners. So we look into the bit of background as to why hyperglycemia is relevant to ICU practice. So we look into pathogenesis that typically happens with hyperglycemia and what are its ramifications. Then, is there any benefit of intensive glucose control in ICU? Because we know that the glycemic control is a quality indicator in intensive care, and what are its benefits is what we would see. And we looked into glycemic control in specific situations, post-operative period, neurocritical care, myocardial infarction, and sepsis. Then we look into, is there any impact of blood glucose variability on the critically ill patients? Then we look into impact of prior glucose control, that when patients is not maintaining good glycemic control prior to admission to ICU, whether this has any impact on the outcome. And then we look into glucose monitoring, what is the right way of monitoring glucose in critically ill, and take home message. So hoping to complete all this in about 20 minutes. So let's take it from there. So the background is, we know for sure, I think most listeners, it's fairly intuitive for us to understand that hyperglycemia in ICU or in a sick patients is associated with increased morbidity and mortality. And this correlation of hyperglycemia having a bearing on morbidity and mortality is lot more relevant and becomes important in non-diabetic patients who manifest with hyperglycemia in ICU as compared to pre-existing diabetes. If someone is already diabetes and they have high sugars, their outcome may not be as bad as someone who is non-diabetic who has a high sugars in ICU. So that is something which an intensivist should bear in mind. As per the ADA, American Diabetic Association, more than 140 milligram per deciliter is defined as hyperglycemia, or HbA1c more than 6.5% is considered as hyperglycemia. So now the whole question is whether should we maintain less than 140 or 140 to 180 is a reasonable range. I think that is where the whole science is evolving, or the evidence or the studies that have been done in this range. So when you look at the global burden of diabetes, it's around 2.8% of the population is diabetic. But when these patients come to ICU, their risk increases up to 15 to 30%, which means when patients come to ICU, the risk of them developing hyperglycemia and critical illness is 15 to 30%, although the global prevalence is 2.8%. And 40 to 90% of intensive care patients can tend to have hyperglycemia. So that is the sort of a data we have. So in the prospective cohort study, so they have shown that in community acquired pneumonia, people who are non-diabetics, when they manifest with hyperglycemia, it had a correlation with increase in the mortality. But in diabetics, in community acquired pneumonia, who are already diabetics, hyperglycemia not necessarily was associated with the worst prognosis. So this is the sort of context we have in the background. So when you look at the pathogenesis, hyperglycemia in ICU can be a determinant of prognosis. So someone who has a high sugars in ICU, especially in someone who has not been pre-existing diabetes, can be associated with a bad outcome, or it can be a marker of severity. So in acute illness, there's a lot of changes that happen. So there are four components that happen. So one of the changes, they'll have increase in the glucagon, and because they have critically unwell, cortisol levels go up, and there is increase in the circulating epinephrine levels. And then in acute illness, there is a reduction in the glucose transport receptors. So GLUT4 is reduced, and there is a reduction of post-insulin receptor signaling that gets reduced. So then they tend to develop insulin resistance. And there is increase in the inflammatory markers. We understand in acute ill, the cytokines and tumor necrosis factor alpha increases. And acutely ill patients, very often they may be getting steroids, they may be on TPN, and mobilization or physical activity will not be happening. So all these have a bearing on the vicious conundrum and the ramifications of hyperglycemia. So this increased glucagon, increased cortisol, and increased epinephrine leads to increased gluconeogenesis and increased lipolysis, and reduced GLUT4 and reduce in the post-insulin receptor signaling leads to insulin resistance, and it can lead to reduced glycogen from the muscle stores. So that also leads to its manifestations, and increase in the cytokines also leads to insulin resistance and increased glucagon. All this together leads to stress hyperglycemia. So this is the vicious conundrum that we see. So all these are the factors which are correlative to stress hyperglycemia that manifests. And this stress hyperglycemia, which happens within ICU, leads to reduce in the immune function of the individual, and the immune hemostasis gets affected. And this can lead to reduced wound healing in critically ill, and it can lead to endothelial dysfunction, and they can lead to procoagulant state and so on and so forth. And there is increase in the inflammatory markers. So this is in a sort of a essence, the whole pathogenesis of stress hyperglycemia, or the pathogenesis of hyperglycemia that manifests in ICU. So now we'll move to benefits of intensive glucose control in intensive care. So there are a few studies which are landmark studies. The first study that made sort of a news about the benefit of intensive glucose therapy came from this Vandenberg study. So this came from the Belgian group in 2001. This was published in NEJM. Here, Vandenberg compared two groups of patients. So this study was done in surgical ICU patients. They compared two groups. One group was maintained on 80 to 110 milligram per deciliter versus 180 to 215 milligrams per deciliter. And they found the group which was maintained on a strict glycemic control, 80 to 110, they had 32% reduction in mortality. There was a significant reduction. So some of the limitation of this group is because it was surgical ICU patients, many of these patients were on TPN. And that's why the rigid sort of a glycemic control was maintained. So this study sort of created a lot of ruffles with the community, saying that strict glycemic control possibly will lead to mortality reduction. And one of the points that was highlighted was many of these patients were on TPN. And this particular study had around 1,548 patients. Then Vandenberg did another study in 2006, and this was done in medical ICU patients, 1,200 patients. Now, where intensive glucose therapy was maintained in one group, and here they found mortality did not uh, manifest the way in the previous study, because if the length of stay was more than 3 days, there was mortality reduction. But in patients whose length of stay was less than 3 days, in fact, mortality was high in patients where intensive glucose therapy, IGTs, intensive glucose therapy was maintained, and that was statistically. So this study basically said within 3 days, it increased mortality, but more than 3 days, it reduced mortality. So it was a little diabolical study, but overall, when they took all the group of patients in medical ICU between insulin glucose therapy versus the control group, there was no difference. So the mortality was 37.3 in the insulin intensive glucose therapy versus 40 in the control group, and it was not statistically significant. So the second Vandenberg study, which was done in MICU, medical ICU patients, was negative. The intensive glucose therapy did not lead to reduction in mortality. So now after this, a very big study came called the nice sugar study. So this still holds relevance in today's practice, and this is a landmark study that came by Australian group in 2009. It was published in NEJM. This was the largest study till date, 6,104 patients. So here they maintained two groups. One was the rigid glycemic or intensive glycemic therapy. So I will use the word intensive glycemic throughout the talk, 81 to 108 versus 140 to 180, and they looked at cardiovascular mortality. And as you see, cardiovascular mortality was more in intensive glucose therapy group as compared to 140 by 180. And hypoglycemia also was more in the intensive glucose therapy as compared to the control group. So, and this again showed that maintaining rigid glycemic control or intensive glucose therapy may not be of much benefit. And in fact, it may lead to increase in mortality. So this study is what we follow. That's why in ICU, most of you would be aware, we take 180 as a cutoff. So we wouldn't want sugars to more than 180. 140 to 180 seems to be an acceptable range even today based on this study and the subsequent studies which we'll talk about. Then there was 4 meta-analysis done to see whether we can reconcile to this sort of a hypothesis that intensive glucose therapy leads to increased mortality. And all these 4 meta-analysis, as you see, one came from US, one came from Canada, one came from China, and the other one from US in 2011. All these meta-analysis showed no benefit of intensive glycemic therapy, and intensive glucose therapy led to increase in the risk of hypoglycemia. So this is our understanding in ICU patients. So now we will move into specific situations or a specific patient conditions. Post-operative period, the study findings were a little different. So this was study in 2009 came from US group where they did a study in 236 patients undergoing vascular surgery, where they compared intensive glucose therapy versus control group 100 to 150 and more than 150. And here in this study, they showed there was intensive glucose therapy led to reduction in the composite endpoint of mortality and occurrence of peri-op MI and heart failure. So this was a positive study which said in post-operative patients, intensive glucose therapy had a beneficial effect. Then there was this other study which came from Israel, done in 410 patients, again intensive glucose therapy versus control group. The risk of infection was significantly less in intensive glucose therapy in post-op patients, and atrial fibrillation, there was 12% reduction in intensive glucose therapy. So in post-op patients, it was found that intensive glucose therapy somehow had a beneficial effect. But when you looked at ICU patients, the NICE study and the meta-analysis really did not show any benefit. In fact, it showed increase in the mortality with intensive glucose therapy. Now the question is about how about in neurocritical care? Neurocritical care, there was this study called the GIST UK trial that came in 2007, done in 933 patients with stroke, ischemic stroke. Intensive glucose therapy did not show any reduction in mortality. And there was no improvement in neurological outcome as well. So it was a negative study. Then there was this other study which came by US group in 46 stroke patients, intensive glucose therapy 31, and 15 patients in the control group. They looked at 30-day neurological outcome. There was no difference. So in neuro ICU, if someone is working neurocritical care in a stroke patients, intensive glucose therapy did not show any benefit with regards to improvement in the neurological outcome. So that is something you can bear in mind. And there was this other study which came from Poland. So where they looked at National Institute of Health stroke scale at admission 24 hours and 30 days. This study was done in 50 patients, but here they showed that the 30-day National Institute of Health stroke score was better in intensive glucose therapy as compared to the control group. So in neurocritical care, two studies were negative. This study from Poland showed positive sort of an effect. But the meta-analysis, which was done from the Canadian group, showed intensive glucose therapy had no impact on mortality in neuro patients. But maintaining 140 to 180, which we follow even in ICU, had fewer unfavorable neurological outcomes, which goes on to show maybe in neuro ICU, we can reconcile saying intensive glucose therapy did not lead to beneficial outcome. Maybe 140 to 180, which anyway we follow in ICU, appears to be safer and appears to be better in improving neurological outcome is what we can sort of reconcile to in neurocritical care. But in post-op, it was a little different. How about in heart attacks or myocardial infarction? So myocardial, the landmark study was Bigami study. So this Bigami study, they took only patients who are at high cardiac risk. And how did they define high cardiac risk? Anyone with age more than 70 years or history of acute MI and heart failure and someone who is on digoxin. And this Digami study came from Sweden. So they divided the population into two groups, low risk group and high risk group. And as I said, the high risk were age more than 70, MI and CCF. So low risk group, they divided into two groups. One got insulin and one got no insulin. High risk also, they divided into two groups, no insulin and insulin. Here, they gave a protocolized insulin therapy. They gave insulin with glucose for all patients with MI for 24 hours, followed by they gave subcutaneous insulin 6 hourly for 3 months for all the patients who had MI. And this was, as you see, this was a very old study, 1999. And 620 patients they took. And this also created news in early 2000s, where they showed hospital mortality was significantly less in any patients with MI who got insulin with glucose. 306 patients, they got that compared to control group. And 3 months mortality appeared to be less, but both were not significant. As you see, the mortality, hospital mortality was less, but it was not statistically significant. But at 1 year mortality, it attained statistical significance. The mortality was 18.6 as compared to control group 26.1%. If you see confidence interval, it was statistically. So mortality reduction happened by 28% at 1 year. So this is an old study which basically said any patients with MI receiving dextrose with insulin for 24 hours and subcutaneous insulin for 3 months had a favorable effect at the end of 1 year. After which, if you, maybe my intensive care friends, the old time, if you recall, this practice was followed at earlier times following MI, there was increasing usage of insulin with dextrose. But subsequently, there was a meta-analysis with 11 randomized controlled trials with 23,000 MI patients which showed there is no benefit of intensive glucose therapy in MI patients. So basically what we can understand is in MI patients, intensive glycemic therapy is of no relevance. So we can still adopt our general ICU policy of 140 to 180 appears reasonable. How about sepsis? Because intensivists, we deal with sepsis day in and day out. So this was a study that came from Germany in 2008, 191 patients with sepsis, and the intensive glucose therapy did not have any benefit. In fact, they found hypo and hyperglycemic levels were much higher when we intended to maintain intensive glycemic therapy. The YSEP study, which came from Germany, again showed no benefit in sepsis with intensive glucose therapy. And nice sugar study, we saw, in fact, it increased cardiovascular mortality with intensive glycemic therapy. There's no, so in sepsis, there's no benefit of intensive glycemic therapy, which is less than 140. 140 to 180 appears reasonable for sepsis patients as well. So this is the current evidence about the whole glycemic studies we have. And now let us look at what is the impact of blood glucose variability on the critically ill patient. So variability means huge fluctuation in the blood sugar, whether it has an impact. So this is a symbol for variability. So increase in the blood glucose variability is shown to have a correlation with increased mortality. And the greater the fluctuation is correlative with worse outcomes. So we should not allow huge fluctuations in the blood glucose level, which is shown to be related to mortality. But then the question is, what is the best measure that you can utilize to look at the variability? So there are 4 measures: standard deviation, and there is mean amplitude of glycemic index, or there is acute change in the glucose levels per hour, and there is glycemic lability index. So these are some of the indices people have used to look at the variability of the blood glucose. Of all these, standard deviation appears to be consistent to show the variability as a good marker. And so basically variability is something which we should not allow. So huge variability is associated with outcomes. And now we look into what is the impact of prior glucose control. So which means to say, if someone comes with a high HbA1c before ICU, so which means they did not have a good glycemic control, whether that has any impact on outcome. So HbA1c more than 6.5%, if we see in ICU, it has a specificity of 100% and sensitivity of 57% to diagnose diabetes, even if they were non-diabetic. And it is shown to be a good predictor of mortality that came from this Croatian study. But this is important for all my intensive friends. Just pay attention. In someone with pre-existing diabetes, someone who has diabetes, hyperglycemia in ICU did not have a correlation with mortality. This was shown in this Dutch study, which came in 2013. And even in someone with pre-existing diabetes, increase in the blood glucose variability did not have any correlation with mortality. This was shown in a UK study, which means someone who is already diabetic before, the fluctuations in blood pressure or even higher sugars did not have a good correlation with regards to the mortality. But if someone is a non-diabetic, which I said earlier, if they manifest with hyperglycemia, that is associated with more deleterious effect. And even the tolerance to hypoglycemia was shown to be better in patients who were pre-existing diabetes, because hypoglycemia symptoms manifested only at 63 milligram per deciliter in pre-existing diabetes. But in non-diabetics, the tolerance to hypoglycemia was poor, which means they manifested with symptoms at 88 milligram per deciliter in non-diabetics. So this is an understanding which every intensivist should have. If someone is pre-existing diabetes, some amount of high glycemia may be still acceptable, because that does not show consistently having a correlation with mortality. So that is about that. So now we look into the glucose monitoring. What is the best way to monitor glucose? So the finger prick method that we use is not accurate in ICU, because ICU is associated with hemodynamic instability and tissue perfusion may be compromised and capillary perfusion may be compromised because of microthrombi. So it may underrepresent the glycemic level. So it is not accurate. So what is suggested is continuous glucose monitor or arterial blood gas. So continuous glucose monitor is something which is being spoken about now, where basically this is done in labile diabetes on an OPD basis. So this is something which we have to look into its usage in ICU, where a sensor is placed and which measures blood sugar every 10 seconds. And this is related to these signals, and average glucose level is monitored every 5 minutes and indicated. So we are looking at future in ICU with continuous glucose monitors of this nature, so that we can mitigate and minimize the variability, blood glucose variability. And continuous glucose monitoring system had a good correlation with arterial blood blood gas glucose is what it is shown. And this was a study from Austria where they did a study comparing continuous glucose monitoring system versus conventional monitoring in ICU. And they found there was 9.9% reduction in the absolute risk of them developing hypoglycemia, because hypoglycemia occurrence also significantly less by using continuous glucose monitoring. So maybe the future of ICU will be looking at continuous glucose monitoring as a standard of care, which will maintain better glycemic levels, reduce the variability of glycemic variability, and possibly outcomes also can be influenced by continuous glucose monitoring. So the take-home message is, although the earlier study, the first Vandenberg study, which said intensive glucose therapy reduces mortality, but all the recent studies have debunked this theory that whether intensive glucose therapy has any bearing on mortality. But intensive glucose therapy possibly has some role in patients who are on TPN, because that's what the first study showed, or in post-op patients. As you see, the two studies that came in post-op showed benefit with intensive glucose therapy. And in someone with a pre-existing diabetes, possibly the benefit of intensive glucose therapy is very less. And intensive glucose therapy leads to increased occurrence of hypoglycemia. The current evidence suggests that the target has to be decided case by case. Case by case, if someone is TPN, try to maintain IGT, intensive glucose. Someone post-op, try to maintain good glycemic control. And Nice Sugar has even said to maintain this target blood glucose happened only less than 50%, even in their study, which means it's very hard to maintain that intensive glucose. So what is reasonable for ICU is maintaining the sugars between 140 to 180 appears reasonable for our intensive care patients. And the newer glucose monitoring techniques like continuous glucose monitoring is something that needs more research, more investigations in ICU setting. So that's the overview of hyperglycemia in ICU. So thank you one and all. So end with this beautiful quote, win in your mind and you'll win in your reality. So you can visit my website, www.drpradeeprangappa.com to rehear to this lecture. So thank you one and all.